Next speaker is Professor Alan Yu. He is from the Manchester Royal Hospital, UK. Professor Alan Yu will be talking on the importance of flow control in glaucoma surgery. That is the most critical part of the glaucoma surgery.
You may need to talk among yourself for about 2 seconds while we try to change this over, and hopefully it would work. I'm very impressed with the yellow bus, by the way. It's very cute. Does it work? No? Hands up if you do non-penetrating surgery here. Oh, okay. 2 people. I don't do any.
I think in Indians, lowering of people did try a lot, but I think in the end, it is easier to go full thickness. It's so much more convenient. And as far as the pressure lowering was concerned, it wasn't, I think with the MIGs coming in, it probably will balance that out, and people would rather do a MIGs than. Yeah, sure, please.
You're right. I mean, it's if you do non-penetrating and if not correctly done, you will have the same result as MIGS, and that is too high for advanced cases. And that's why you have to do a really good dissection, and then it will work if you do the goniopuncture, like trabeculectomy. They have same results, but I would prefer in India, since the follow-up is not always that easy, especially if you're working in rural places, then do as I do in Africa. I do penetrating deep sclerectomy, and interestingly, the results, I did not have time to show you results, but the results is about a pressure of between 10 and 12 maximum without mitomycin. It's very interesting.
Yeah, but very few of us will have the beautiful surgical technique that you showed. That was too good.
Thank you. So I'm going to talk about flow control. It's a weird subject, but just bear with me. These are my usual financial disclosure you've seen before. Okay, I told you this morning I'm a stenter and not a ripper, and I'm going to tell you this is the second thing. I'm the biggest believer in this. Okay, it's not really the destination, it's the journey. And I think your target, your low surgical IOP is your destination. We spend a huge amount of time comparing our destination, but we don't really talk about the journey, how we get down there. And I think that's what this talk is all about, how we're going to get down to that level and what journey we take. And none of the paper describe the journey very well. You have your IOP and your medication, that's your destination. They don't really talk about the journey. We talked about loads of mix this morning. We spent 2 hours talking about mix, and ultimately all the ab-internal mix, like you've just said, and Andre very rightly point out, that if we're going to restore physiology, your physiological IOP is 16 plus a 2 minus 2 standard deviation. So that's what you're going to get, and that's what everybody is getting, around about 16, 17 with all the canal-based surgery. So if your patient needs to go lower, and a lot of them do, then you're going to have to go non-physiological. You're going to have to shunt your fluids somewhere else. You all know that. That's why we have a trap, we have a tube, and Andres has DS, and he's shunting the fluid somewhere else. And then we have some subconjunctival device that he also mentioned, which is the Zen and the PreserFlow, with shunting it to subconjunctival space. So, and it's all about the flow control. So with the Zen and the PreserFlow, the idea is that we have some control of flow using physics. We have a fixed length device and a fixed lumen. That gives you resistance. So that allows you to reduce your hypotenuse. When you stick it into the eye, it flows immediately and your pressure will be low. And then as low as physics tells you it would go because of the lumen size, and then as the conjunctiva starts scarring, your pressure will come up. And all you have is to control conjunctival scarring. So you do your pre-op preparation, you pick the right patient, you slap your mitral on as hard as you can, and then you get what you get if you put the device in correctly. And this is what we get. Doesn't matter whose series you look at. This is the Zen. You look at Andres, who showed you this morning. This is our pan-European group. We're getting down to around about 14, 15. And that's the floor that we seem to be getting with the Zen. We had some paratube leak, so we had some hypotony with the Zen. So then now we have the PRESERFLO, which is a bigger lumen device, but is implanted ab-externally, allow us to place it better, avoid the tenon, we put it sub-tenon rather than shove it into the tenon. We have no paratube leak, and then we now ended up with a bleb that is far superior than we've had with the Zen. So good that I'm happy to put it inferior nasally when I need to, which is like one of these patients that you can see when I can't go at the top. You get a beautiful looking bleb because we cover it with tenon, but if you put it against a trap, we're still not getting as low as the trabeculectomy, but purely because that your device has a built-in resistance. So you all know this. This is what a trabeculectomy is like. Your conjunctiva has no resistance to begin with, and then the conjunctival resistance will go up with time. You're going to lower that as much as you can with your mitomycin C. But in a trap, as the pressure goes up, I can lower my scleral flap resistance by releasable suture. I can take it out and open your flow to overcome the conjunctival resistance, and in a combination, get us down to 10 and 11 that we want. Andre does very similar thing by creating a decimate window. He peels beautifully, so then there is a built-in resistance in there and an egress of fluid. So his startup pressure is low, gradually goes up, and then he can gonio puncture to get the resistance lower if he wants to. And of course he slaps on mitomycin C because he wants that conjunctival resistance to go down. That is the control of flow that we have. And if you don't have this gradual titration with releasable sutures, then you're just waiting for the pressure to go up, and that's not control of flow. Then you're gonna have immediate post-op hypotony that no one wants. The problem with the Zen and the PRESERFLO, because it's got a built-in resistance that you cannot relieve and you cannot remove. So you have that 6 millimeter mercury resistance. So when you begin with, you're not gonna go below 6, so you can sleep well, but that 6 millimeter is gonna add on top once the conjunctival resistance kicks in. That's why a Zen and a PRESERFLO will never, ever go lower than your trabeculectomy. That's just physics. So nowadays, this is what I believe trabeculectomy, how it should be done. It should be done with an AC maintainer. So then you can have an AC maintain and you can assess flow. You can't assess flow with a flat AC pumping it up occasionally to see how it egress. That's not normal. You have an AC maintainer set at a certain height so you can assess flow. And then you have releasable suture that you can release. I don't understand why we will still use fixed sutures and argon laser when releasable are so simple to do in clinic. And that's how my trap is, that's how we teach everybody, and that's how roughly how we do things in the UK. And when it comes to the tube, we have the same thing about flow control, right? For the last 25 years, we've been putting up, and that is the correct word, we've been putting up with the RMED and the bar valve. None of you want one in your eyes because they are horrible things. RMED is a worldwide winner because it has a built-in flow control. It has a built-in resistance. It's not a valve, it has a resistance. So it can give you immediate flow, it doesn't go too low, but then that resistance is gonna add to it when you get encapsulation. So then it will never go as low as a bar valve, which is a straight tube with a plate, which has been shown twice that the RMED doesn't get you as low because that valve, you want it to be removed 3 months later, but you can't. You're gonna have to put up with that valve, but then it gives you immediate flow. While a bar valve doesn't give you immediate flow and you do 10 billion things to stent it to try to control flow, which is very, very DIY. So now we've moved on. I've not put an RMED or a bar valve for the last 4 years because we have the new pore tube. So pore tube, designed by Pore Tube, has a smaller tube. The smaller lumen tube is 127 microns, which I think is the smallest lumen you can get away with no resistance. Any smaller, you're gonna add resistance to it. Any bigger is a waste of time and a waste of space. So then when you, by chance, stent it with a 6-0 proline, you get the smallest amount of egress coming out at the back, which you can see before, or just about a tiny trickle. That will give you a very predictable pre-op day 1 IOP. So we have immediate flow, but have a very low risk of hypotony. Certainly in our unit, it was about 1 or 2%. Because of this combination. And then you can remove the suture 3 months later to give you a second bite of the cherry to lower your resistance more to drop your pressure. So the lumen is surprisingly only slightly bigger than an iStent. And then this is the egress you get with a 6-0 proline. Very small trickle, way less than an RMED, and we have far less hypotony compared to an RMED, far less. But we get a big plate. So 3 years down the line, when you look at our results, we are getting exactly the same as a bar valve. We have the same plate size. We have a lumen and a tube that offers you no resistance. Once we pull the ripcord, in 50% of cases, we're getting down to 12.6, which is a valve-out level, not an RMAT level, but with a far better risk profile and a far better IOP journey, which is a combination of the two. But you're going to talk about variability of flow, you're going to have to talk about the iWatch, which come from Switzerland. Andre is heavily involved. This is the only device currently commercially available to give you a continuous adjustment of IOP. So then we have the iWatch, basically has got a tube inside with a magnetically controlled plate that I can rotate and open to adjust flow, just like a tap, exactly like a tap, attached to a tube and a plate. So you can see on the video here, inside is magnetic control. I put a compass on it, tells me it's now fully open. And I swing a magnet, turn it, and then now it's fully closed, exactly like a tap. And then I connect it to a tube. So you can see that when it's in the eye, it's set to closed, so there's bone dry, there is no flow. There are many occasions when I want to do a drainage procedure and offer me no flow to begin with. People whose risk of malignant glaucoma, Sturge Weber, I don't want flow to begin with. And then no flow, and then I can open it. Postoperatively in clinic, hover it over your eye, then I can open it to adjust flow, attach it to a tube, and then we have the first fully adjustable flow device. You can see it at the slit lamp. We sit down in a scleral bed, cover it with a single layer of Tutaplast. It's actually pretty good, and it's not as bulky as it sounds. Certainly now, when we sit it in the sclera, you get a much better looking thing. And that's what it looked like in clinic. You can check it with a compass, boom. It tells you it's set to 1, set to 2, set to partially open. I can adjust it whenever I need. And this is our global data. A lot of it come from Andre, some from the UK, a little bit of Greek. We're getting down, again, to the valve-out level. Of course it should. It has the same plate. But this is the neatest thing that we do. This is first described by Andre, taught me this. And we've done more of this than primary procedure. We do an iWatch rescue. If you've got a valve-out and an RMAT 10 years down the line is going hypotenuse because they're uvitic, I can fit an iWatch retrospectively back into the eye. And that's what it is. You take the tube out, close the hole, fit an iWatch on top, and then we attach your tube to it. So now I have controllable flow, and now I introduce a tap to your existing tube to control flow. And that's what it looks like that when you can just attach the tube onto it. 2 slides left. So that's it. This is going to be the first outing of the latest generation of flow control. So this is the Calibri system from the US, which is non-commercial, non-FDA approved, non-CE marked. But this is it. This is a pressure flow on steroid. This is a pressure flow with multiple channels that we can switch and open using a green light laser in clinic. So we implanted a bit like a pressure flow with a very posterior drainage made of silicone with 3 channels that you can select to drain in any combinations you like. So this is in the eye, and then let me allow you run this simulation, then I'll shut up. So basically, you have 2 places where you can shine a green light laser, then we'll switch the channel, open and close, in clinic. No more magnet, which is so 20-year technology. So this is laser adjusted. We shine at it, and then it will change that nitinol valve. It will flip open 1 channel. So there's a constant middle channel, give you a tiny bit of flow. We can then select the second channel to run to give you more lumen. And we can select the 3rd channel for you to run to give you more lumen. So then we ended up adjusting it in clinic using a laser, split-second control of flow. No more sutures. This is physics to the nth degree. We can have a baseline flow, low flow, moderate flow, maximum flow, selecting it in clinic based on the IOP. This is coming, and this, I think, is what technology gives us. So there you have it. When you come to control of flow, every man's dream, whether you want to trickle or whether you want to squirt, you know, now we have the technology, so you are fully in control. Thank you.
Thank you so much for your wonderful magic talk on various devices. It looks very interesting to use that. Let's hope for the best to come in.
Yeah.